Yes, Amit.
Hello, everyone.
Yes, sir, we are
And
live now.
yes, thank you. Good evening, everyone, and I welcome you on behalf of Diabetes India and IDF Southeast Asia for this program of ADA Learning. And as you know that yesterday we heard the news of Dr. Akhtar Hussein's passing away, and this is something which came to all of us as a shocker. And as a IDF Southeast Asia, we believe that it is a huge loss not only to each and everyone who is connected with diabetes care, but it is a big global loss for the diabetes community. And we remember him and we pray for him and for his family. We stand with his family today. And tomorrow, as you all know, we are going to have a prayer meeting in his remembrance at 8:30 a.m. India Standard Time. So I will request all the attendees who are here that they can join us again tomorrow at 8:30 a.m. to offer their homage to Dr. Akhtar Hussain, IDF President. With this, on this sad note, as you all know, that his only objective was to increase diabetes awareness, increase diabetes education, and to have diabetes care accessible to each and everyone all across the globe. So that in his spirit, so we are not discontinuing this program. We are continuing with the program, and today we have a very special session in which we have one of the esteemed moderator from Sri Lanka, Dr. Dimuthu, who has joined us. Welcome, Dr. Dimuthu. And we have Dr. Rakesh Sahai, who is currently the president of RSSDI, and we have Dr. Jyoti Dev with us, who is currently the president of Diabetes Technology Trust of India, and also an EC member of RSSDI. So we will start the program today, and we have very interesting topics lined up. So I will request RXT to display the introduction slide of Dr. Dimuthu, and then she will take over the session and introduce each speaker one by one. So Dr. Dimuthu, welcome on this platform of Diabetes India and IDF Southeast Asia. And Dr. Dimuthu is from Sri Lanka. She is a consultant endocrinologist at Sri Jayawardhanapura General Hospital, Novegoda, Sri Lanka. And she is currently the president of Sri Lanka College of Endocrinologists and executive committee member of SAFIS. So welcome, Dr. Dimuthu. And now I hand over the session to you to take the proceedings further. And whenever RX team will display the slides of the speaker when you are introducing them.
Thank you so much. So today's we've got
Dr. Rakesh Sahai is the first speaker.
Okay, so we've got two renowned
RX team,
speakers.
yes.
Yeah, so Dr. Rakesh Sahi is going to be the first speaker. The CV is, of course, like it's a very outstanding CV. So for the attendees, he's a very well-known speaker to all of us. But I would like to briefly summarize his CV. Dr. Rakesh Sahi is the professor of endocrinology, Osmania Medical College, Osmania General Hospital, Hyderabad. And he is the president, Research Society for Study of Diabetes in India. And he's also the president, South Asian Federation of Endocrine Societies, SAFIS, and also the immediate past president of the Endocrine Society of India. Dr. Rakesh Sahi is going to talk to us about the topic of the talk is championing LDL cholesterol management in diabetes care. So it's a very important topic. So all of us know that as we're actually moving away from a glucocentric approach to a cardiorenal approach. And especially cardiovascular risk reduction. So that would be the main focus as when it comes to diabetes care at present. So I'm sure this discussion is going to be the talk and the discussion is going to be a very productive one. So I would like to invite Dr. Rakesh Sahi to deliver his talk.
So thank you, Dr. Dimuthu, for the kind words of introduction. And what I would do in the next 20 minutes that I have is discuss about some of the topic that I'm going to cover is about championing LDL reduction in people with diabetes. And as Dr. Dimuthu has highlighted that we are looking at a more of looking beyond glucose control and looking at reducing the cardiovascular risk in people with diabetes, because cardiovascular disease are ultimately the main cause of morbidity and mortality in most of our patients with diabetes. And targeting the LDL is very important. And I'll be discussing about a few presentations which happened at the ADA regarding the LDL reduction. And although I mean, and also take through some of the some of our own data from data from the Lipid Association guidelines and all that, so that to compare and contrast, because what we say that the targets in different populations, how they would vary in different populations. So I try to cover those aspects and a little about LPA. Let me share my screen. Is my screen visible? Yeah. So I'll also conclude by giving a few glimpses of new data that was presented on the reduction of LP little a. So I'll just quickly run through those slides and discuss mostly about the LDL levels. So at the outset, I would like to thank Dr. Bansi and Dr. Amit Gupta for inviting me to be here, and also our homage and our respects to the departed soul. We are dedicating this series to him, to the message. I mean, to the campaign that he did for diabetes and for championing the cause of diabetes. So if you look at the lipids levels in people with the myocardial infarction, what we see is that they are very important, because if you look at the InterHeart study, which had more than 15,000 patients with acute myocardial infarction and another similar number of controls from 52 countries across the globe, what we saw was that the lipid levels were the most important ones, which were responsible for causing the MI. And this is probably one of the most modifiable risk factors, because there are several risk factors which cannot be modified, but amongst the modifiable risk factors, this is probably one of the most important ones. And this stood out very prominently, and that once again highlights the need for appropriate lipid management in people with diabetes. Now, if you look at the various lipid fractions which are related to the risk of atherosclerosis, we have the LDL, which is causally associated with ASCVD, and lowering LDL clearly reduces the risk of ASCVD proportional to the absolutely achieved reduction in LDL levels. Triglycerides are also important. There's been a lot of controversy regarding the triglycerides, whether triglyceride reduction actually brings down the ASCVD risk or not. But nevertheless, what is important to understand is that when the triglycerides are high, there is a compositional change in the LDL levels, and also the HDL levels are lower. And because of this, there is a increased risk and increased risk with the increasing triglyceride levels. And triglyceride reduction probably has been shown. I mean, not with every agent that has been tried, there has been an improvement, but with some of the agents, there has been some improvement which has been seen. The HDL cholesterol is again a very controversial this thing that, although we know very a lot of data about the inverse association between plasma LDL and the HDL cholesterol levels and the risk of ASCVD, but interventional studies looking at HDL reduction HDL increase have never been shown to be associated with the reduction in the ASCVD events. Now, the other important molecule that I'm going to quickly show a little about is also the LPA, which is a LDL particle with the ApoA moiety, which is covalently bound to its ApoB component. And this is proatherogenic, and it has been attributed to have procoagulant effects also, which add to the proatherogenic effects. And these levels of plasma LPA have been shown to be consistently increasing in people with increasing risk of ASCVD. And the LPA levels, however, are genetically determined and remain and the hitherto understood concept was that we probably cannot do much about it, but some of the newer data which shows that there are probably, we are looking at agents which can bring down the LPA levels, and we need to then look at whether reducing the LPA levels actually brings about a reduction in the cardiovascular events. So let us now focus on the LDL itself. LDL, we have got a lot of observational epidemiological studies which have shown that LDL has a causal relationship to the atherosclerotic cardiovascular disease. There have been Mendelian randomization genetic analysis which have shown the causal association of LDL. Similarly, we have got randomized clinical trials with LDL reduction which have shown the benefit, and several experiments, animal experiments also, which have shown the benefits of LDL lowering. And as is illustrated here, we have data from a lot of randomized trials which have looked at primary prevention trials. They are the primary prevention trials, and then we have the secondary prevention trials which have clearly shown that with LDL lowering, with every millimole of LDL lowering, there's almost about a 30% reduction in the risk of cardiovascular events. And this and the trials have been, numerous trials have been carried out which have shown these benefits. And what we have understood from all these clinical trials is that the three principles that we have understood is that the lower the LDL, it is better. The faster the lowering that is done, it is better. And the longer that we are able to keep the LDL lower, then again it is better in terms of reducing the cardiovascular risk. And then regarding the controversy, that is, regarding the issue of whether LDL lowering has the same benefit in diabetics as much as in non-diabetics. So we have a lot of data to support the finding, that support the view that LDL lowering in people with diabetes, if not producing better results, has equally good results as in people with non-diabetics. It may, in fact, give better results than in diabetics than in non-diabetics. And we have clearly seen that there is a clear benefit in with LDL lowering in people with diabetes also, as much as it is seen in non-diabetics. And then the other issue that we have that we need to look at is that I'm not going into details of each of these issues, but I'm highlighting some of the points which have come out of several different clinical trials. And if you look at the risk reduction that is produced by, say, low to moderate intensity statin use, it is about 1.3 versus 1.2. That is, relative risk of 10% risk reduction is happening. There may be a A1C increase. This is another aspect that has come out in the about the LDL lowering with the use of statins, is that statins can increase the development of new onset diabetes. They can worsen the glycemic control. And so what we see is with low to moderate intensity statin, while we have a 10% relative risk reduction in terms of cardiovascular events, there was a A1C increase by 0.06% on the average. And similarly, with high intensity statin, the relative risk reduction comes down quite significantly to 36% or higher, and HbA1c rises is just a marginal increase from what we have seen with the low to moderate intensity statin. So this clearly shows that there is a clear risk benefit ratio that shows that the benefit far outweighs the risk in terms of worsening of glycemic control or the development of new onset diabetes in people with the use of statins, moderate to high intensity statins. So in the ADA standards of care, the latest one, we see that that with regard to primary prevention, it's mentioned that for people with diabetes age 40 to 75 years at higher cardiovascular risk, including those with one or more ASCVD risk factors, it is recommended to use high intensity statin to reduce the LDL cholesterol by more than 50% of the baseline, and to target a LDL cholesterol to a goal of less than 70 milligram per DL. So in people with diabetes who have no previous cardiovascular events, it is recommended to bring it down to less than 70 milligram per DL. And this is a very strong recommendation, class A recommendation. For secondary prevention, the recommendation is to use a high intensity statin to target a LDL cholesterol reduction of more than 50% from baseline, and a LDL cholesterol goal of less than 55. And so this is again a strong recommendation. The addition of ezetimibe or a PCSK9 inhibitor with proven benefit in this population is recommended if the goal is not achieved. And this is a moderately strong recommendation in terms of using these additional agents, which are to be used in addition to a statin, if the statin is not able to bring the LDL cholesterol to the goal that we are looking at. So if we look at the MACE reduction with the statin therapy, there's consistent data from all the clinical trials which have looked at the cardiovascular outcomes, and there's a 22% lower incidence of major vascular events per 1 millimole difference in LDL cholesterol. As I mentioned earlier, that with every millimole of LDL reduction, the difference in the reduction in cardiovascular events is quite significant. The reduced IT trial with the use of icosapentethyl has shown in the diabetes subgroup has also shown the benefit of triglyceride lowering with the use of icosapentethyl. Now, as we said, as I mentioned, that the LDL goals would vary based on the on those who have got based on the risk, cardiovascular risk in these individuals. Those at lower risk, probably the goal is higher, and as we go down, so we spoke about LDL target in different categories of people. Those with highest risk probably have should have a LDL of less than 50. And in fact, I would just allude to what the Indian recommendations are in terms of the goals, as we see, which probably are a little more stringent as compared to the goals even enunciated by the American American Association of Clinical Cardiologists and also the ADA. So in the secondary prevention group, what we're saying is that with clinical ASCVD, healthy lifestyle, ASCVD risk not at very high risk, we would those less than 75, we would use a high intensity statin with a goal of less than 50, LDL target of less than 50. And if on maximal statin therapy and LDL is more than 70, then ezetimibe may be a reasonable addition. And so that is how, as we mentioned, that the goal for primary prevention is kept at 70. The goal for secondary prevention is kept at 55. And if you look at the recommendations, this is for the primary prevention group. We saw the recommendations for the secondary prevention group in the previous slide. And so when you look at what we are looking at from the Indian perspective, is that we find, or from a South Asian perspective, I would say most of this holds good for even for Sri Lanka. Dr. B. Muthu would tell us about that. So we are saying that we need slightly more stringent goals, because we see that our population, see that we tend to develop cardiovascular disease at a younger age. We tend to have more extensive disease. And while diabetes also occurs at a younger age, and the course of ASCVD also appears to be more fulminant with higher mortality. And so the Lipid Association of India developed revised guidelines with more aggressive lipid lowering goals as compared to the goals given by most of the other countries across the world. So this is the Lipid Association India 2023 guidelines, which I would like to highlight here. Although we are discussing about what was presented at the AD, but this is important to compare and contrast with the guidelines with the international and what the guidelines are suggested by the Lipid Association of India. So they have highlighted the need for risk stratification. They have highlighted the risk groups as low risk, moderate risk, high risk, very high risk, and a category of extreme risk. And the risk categorization is done based on the major ASCVD risk factors, as are listed here: blood pressure, low HDL, current smoking, and age more than 45 in males and more than 55 in females. These are the major cardiovascular risk factors. High risk features are again, family history, and then CKD stage 3, B or 4, ApoB level of more than 130, extreme elevation of a single risk factor, or LPA level more than 50, and the presence of metabolic syndrome, or non-alcoholic fatty liver disease again is added into the risk stratification, because this is something which has been understood in the recent years, that presence of non-alcoholic fatty liver disease with fibrosis grade 2 or 3 fibrosis increases the cardiovascular risk in these individuals. And coronary artery calcium scoring of 1 to 99 or less than 70th centile. And the risk modifiers are the LPA levels when it is in the range of 20 to 49, and IFG, increased waist circumference, the individual components, the metabolic syndrome, then premature menopause, high polygenic risk score, air pollution, human immune, HIV infection, triglycerides more than 150, or fasting more than 175, non-fasting triglycerides. Fasting triglycerides more than 150, or non-fasting triglycerides more than 175. So these are all the individual components of the metabolic syndrome, and some of the other factors like the lower LPA levels and the hsCRP levels. So this is how they categorize. And the low risk, the target is the lifetime CVD risk is less than 30%, moderate risk more than 30%, and as you can see, the high risk are those with previous ASCVD which have one of those high risk factors. So the goal of LDL is it didn't come up in this slide, but what I would like to highlight is that the goal is, say in this group it is 100, here it comes down to 70, high risk group it comes down to 55, and then in these groups it is targeted to keep the LDL around 30. So this is the current targets that are proposed by the LAI, Lipid Association of India. So as what is the recommendation to control the LDL levels? As I have mentioned that, the primary therapy is with statins, high dose of statins, high intensity statin, and then high potency statin, the highest recommended dose, tolerable dose to reach the goal. If the LDL goal is not reached, then you look at adding ezetimibe. If still the LDL goal is not reached, then the next agent to be considered is a PCSK9 inhibitor, and the PCSK9 inhibitor is as we know, the available agents are with parenteral therapy to be given either one of them is once a month, and then you have got the once in 15 days therapy, and this is how we need to look at approaching the LDL targets. Patients with diabetes have a higher rate of MACE than persons without diabetes, and there is need for LDL lowering, which is clearly related to the CV outcomes, and statin therapies have a clear benefit in terms of ASCVD risk reduction, and non-statin therapies provide the same risk reduction per millimole of LDL reduction as statins, and they are recommended by AHA, ACC, and European Society of Cardiology, as well as the American Diabetes Association, in those who are not able to reach the goals with statins. So then I would quickly spend a minute or two on LPA, because there's some new findings which are presented, some new data on some of the new molecules which are being studied. So I just wanted to give you glimpses of that. So we know that LPA, I just spoke about what LPA is. So basically it is genetically determined. One of the important factors is that there's a lot of variability in the LPA levels, and up to 90% of the variability arises from the genetic factors only, the LPA gene itself. And the LPA levels are comparatively resistant to conventional methods of LDL lowering, including lifestyle interventions, and the LPA levels are determined by both the rates of production and clearance. Primary determinant is the production of LPA. And so LPA has been clearly shown, as in several studies, to be linked to the cardiovascular disease morbidity, and the mechanism of action of LPA in CVD is in terms of their pro-atherogenic, pro-atherosclerotic or pro-atherogenic effects. They have pro-calcific effects, pro-thrombotic effects also, and because of the PAI with the they also have pro-inflammatory effects, which are mediated by the which are seen with with this molecule, and therefore they have several mechanisms by which they are modulating the cardiovascular risk. So what are the pharmaceutical approaches? Because we have seen that the conventional therapies have not been shown to reduce the LPA levels. Any significant level reduction has not been seen with statins or the non-statin therapies. Only with the PCSK9 inhibitors, there has been some reduction in LPA levels, which has been seen. And so there are several new investigational drugs which are being tried, which are mostly these small RNA molecules, the silencing RNA molecules, and then we have two different classes of molecules: the antisense oligonucleotides and this uh, small antisense RNA molecules. So these actually interfere with the production of this molecule at the nuclear level by inhibiting the transcription of the mRNA, and they inhibit the production of formation of LPA levels. So the different ones which have been tried are pelicarsen, which has been studied these are the phase 2 trials where it has been studied, and it has shown a reduction in LPA levels. And then we have got another molecule called olpasiran, which has also been has come to phase 2 studies, which have with different doses. We have seen the improvement in the LPA levels, and there have been trials which have included a significant number of this is probably a phase 3 trial, which is enrolling patients with LPA levels more than 70. And we are anticipating this trial to be completed next year. And then we have another trial, which is again looking at which probably will be completed in 2 years' time from now. So we are looking at these phase 3 trials. The phase 2 trials have shown benefits. The phase 3 trials are on, and we are looking forward to the results from these phase 3 trials. There's another molecule, moalaplin, which has also been studied, and which is again working through similar mechanisms. And we also have data from the phase 1 data from this molecule, and the phase 2 data is awaited. So what we're saying is that LPA and ASCVD risk in patients with existing type 2 diabetes is clearly seen. The association is clearly seen, and clinical outcome data suggest a beneficial effect of LPA lowering on CV endpoints in patients with type 2 diabetes. More studies are needed to characterize the properties of the atherosclerotic lesions in individuals with both type 2 diabetes and elevated LPA levels, and to evaluate the benefits of targeting LPA lowering in this population. So this is something which we look forward to in the next few years. We may be hearing more about this, but I just wanted to show you glimpses of some of the studies which are presented at the ADA. And so I think I've just mentioned these, that LPA is something which we have to watch out for in the coming years. Thank you. I'll conclude here, and we'll have some discussion. You are muted, madam.
Okay, thank you very much, Dr. Sahe, for that comprehensive outline. The highlights were taken from the ADA meeting. So Dr. Sahe highlighted the importance of LDLs with regard to reducing the cardiovascular risk in existing diabetes. And an important point I'd like to reiterate, the lower the better, the faster the better, and the longer the better. So that's an important take-home message. And also, I thought that Dr. Sahe showed the summarized version of the local guideline, the Indian Lipid Association, Lipid Association of India. So actually, I mean, for the neighboring countries also, I think it's good to have a sort of a dialogue in time to come about it may be very relevant to us. So this is something that we need to discuss further. And also he highlighted about the importance of using LPA lowering treatment in existing diabetes as well. So I think the questions we could take up at the end of both lectures. But before going on to the second lecture, we would like to hand over to the sponsors for their message. The organizers, over to you for the sponsors' message.
iCan, your new continuous glucose monitoring system for all people with diabetes. Easy to apply and comfortable to wear. Real-time glucose monitoring, continuous 3-minute connectivity. Every time iCan. Forget about the unawareness of hypo and hyperglycemia and pain of finger pricks. Forget about interference from vitamin C. Forget about worries about water when you're bathing or even surfing. iCan is water resistant to 8 feet for 2 hours. iCan has a 15-day wear life. With iCan CGM app, you can check your blood glucose anytime and anywhere. With iCan Reach app, you can share your data with loved ones. iCan makes managing diabetes easier so that you can enjoy activities of daily living effortlessly. Set your own alerts for low and high glucose levels. No worries, even at bedtime. iCan provides real-life accuracy. iCan empowers you with self-management. Your choice, iCan.
Okay, thank you. So let's move on to the next talk. So we have another renowned speaker. So can I see the slide, please? The next slide. Okay, so the topic of the talk is learning from ADA, diabetes technologies. It's going to be a very interesting and important topic. So we have Dr. Jyoti Dev, Kesava Dev. Again, a very impressive CV, but I'll try to summarize so for the participants. Dr. Jyoti Dev is the chairman, Jyoti Dev's Diabetes Research Center, Trivandrum, Kochi, Haripad. He's the editor-in-chief, International Journal of Diabetes and Technology. He's the organizing chairperson, Jyoti Dev's Professional Education Forum, and the national president of Diabetes Technology Trust of India. He's also in the Central Executive Committee. He's a Central Executive Committee member of RSSDI and AIAARO. So there are so many affiliations and positions, he has been holding. So either for the interest of time, I would like to hand over to Dr. Jyoti Dev to talk to us on diabetes technology. Over to you, Dr. Jyoti Dev.
Thank you. Thank you very much, Dr. Dimuthu, for the kind words of introduction. So let me also thank my dear friends, Dr. Benshi, Dr. Amit, and the group, and the friends at Diabetes India and IDF Southeast Asia for inviting me to be part of this very important program. And honored to speak along with our President of RSSDA, Dr. Rakesh Sahay. So let me share my slides. So I am going to speak on technologies from the American Diabetes Association, but before that, fondly remembering Dr. Akhtar Hussain, who left us a day before, and he has been a very close friend to all of us. Heartfelt condolences and our prayers from all the friends in India. And our center in Trivandrum is also an IDF recognized center for diabetes care. My sincere prayers. So these are my disclosures. I always used to start my lecture with a peek into the history. And since it is an ADA learning capsule, let me go back to the memories of my first ADA. And the first time I attended the American Diabetes Association in the year 2003, and that was when I was an endocrine fellow at the Mayo Clinic, and I traveled from Rochester to New Orleans. And these are some of the sweet memories. So when I am summarizing the technologies from the ADA 2024, it is not that easy because there were a lot of displays and there were a lot of lectures and reviews on technology. So I'll be only discussing those which are of a direct impact, and it will have a direct clinical impact in practice of diabetology. This is not the usual Libre that we are familiar with. This is not even Libre 3. This is Libre 3 Plus. Probably the world's smallest sensor, and that too an integrated sensor. So when I say integrated continuous glucose monitoring sensor, these are the devices which are approved for use with other systems, including a third-party insulin pump. And you can also visualize the MAD over here. It is a very small MAD, and this is smaller than the MAD, 1% smaller, or when compared to the Libre in India, it is far more reliable. And you know that 3 to 5% of the patients on continuous glucose monitoring devices, they develop allergy. And this is devoid of MBP or IBOA, so that the allergy, the skin allergy will also be significantly less. And you know that the usual sensors, they can tolerate only up to 500 milligrams of ascorbic acid, and above that it will provide you with false high readings. And here, the vitamin C interference can be up to more than 1,000 milligrams per day. And no discussion on technology is complete without referring to artificial intelligence. So how can artificial intelligence and its integration change diabetes practice? And this has been a topic which has been extensively been there throughout the American Diabetes Association 2024. So for the basic learners, what is AI? It refers to the computer and the ability of a computer to think and learn like a human being. And when you are thinking beyond AI, it is machine learning. When you are providing the data, and with more and more of data, it learns from the data, enhancing the performance. And it doesn't require a programming. And when you are shifting from ML to deep learning, it employs multiple layers of neural network to find intricate patterns. And it is even able to recognize your image or even speech. And these are the multiple modalities by which you can have AI in the clinical practice of diabetology, research in clinical trials, and prediction, in the early recognition of complications. Generative AI is different. Generative AI can even create new contents based on the learning and training capabilities. And this is an article which appeared in New England Journal of Medicine, which is also discussed at the ADA. And this is an examination for the doctors. And this is GPT versus the human doctors, the resident physicians. And the GPT-4 excelled in psychiatry, in general surgery, in internal medicine. The performance was relatively poor in pediatrics and gynecology. So when I was discussing with another group of engineers, they were telling me that in the next version of GPT, it will excel in all these specialties. So even now, it is at par or even better than the human doctors in having a passing score of 65% for the US licensing examination. So that is where we are currently positioned with respect to where exactly is artificial intelligence in the space of medicine. And diabetes is probably the best quantified disease. Best quantified disease among all the chronic illnesses, for creating a model, for simulating a disease, for automatically controlling the human metabolic system. So I will briefly discuss 2 or 3 entities. You know, for meal detection, we do have very limited available resources. So detection of meals and physical activity is still not possible in the commercially available automated insulin delivery systems. And this is the data from the Tidepool database to recurrent neural networks, that is RNN. So in conclusion, long short-term memory, that is LSTM, using input data can provide best performance in detecting the meal. So we are gradually entering an era where the devices can automatically, without meal announcements, detect the meal and even physical activity. What about hypoglycemia? I personally consider that hypoglycemia is the number one reason for poor control of diabetes globally, because all of us are afraid, because the physicians are fearful, the patients are apprehensive in aggressively treating or uptitrating the medicines because people can die of a hypoglycemia. So what about predicting hypoglycemia during aerobic exercise? You know, sometimes it can be hypo, and at times during exercise, especially muscle strengthening or a mixed exercise, it can be even hyperglycemia. And this is again using the machine learning models, decision tree and random forest, 90 exercise observations collected from 12 people with type 1 diabetes. So in conclusion, in future, exercise-induced hypoglycemia could be accurately predicted and could be averted in majority of cases. So we are now having the help of AI in most of the spaces where there is an existing gap in the treatment. And this is again back to the automated insulin delivery devices. And in the commercially available systems, we are using algorithms. It is equation driven. For example, in 780G, we are making use of proportional integral derivative. And the Omnipod 5, which is not available in India. And in this AID, it is a model predictive control. But the future will be artificial intelligence data driven control. And that is going to be the neural network artificial pancreas. This was discussed in detail at the EASD as well as in the American Diabetes Association. And what exactly is neural network artificial pancreas? Here again, you are training on either real or in silico data, and the neural network can approximate the insulin dosing rule, reducing the insulin delivery at the time of a hypo, increasing the delivery when it is predicting a hyperglycemia, or even automatically suspending the delivery of insulin with high level of precision at any level. And this is comparing, this is the first NAP study, that is neural net artificial pancreas, comparing against University of Michigan model predictive control. Look at the percentage time in range, above range and below range. It's almost the same as NAP. So the NAP is closely matching with the existing model predictive control algorithm. And one unique feature is it is requiring 6 times lower computational demands. So the future could be much more cost effective. We probably will be having pretty inexpensive devices requiring less cumbersome devices for automated insulin delivery. So diabetes, remember, it is one of the best quantified human conditions for AI generation. With respect to the machine learning, predicting the risk of diabetes and treatment selections. We are in an era of precision diabetology. What about AI? Machine learning models within the electronic health records to predict diabetes complications, to accurately suggest which treatment to be given to a particular patient, and the future state of the patients, diversity and the subgroups in EHR, all those parameters are also considered when you are personalizing the care with fair and ethical machine learning. And this is another step forward. Currently, in almost all the commercially available automated insulin delivery devices, we are only depending on continuous glucose monitoring data, only depending upon the algorithms. What about wearable devices? The patients wearing the devices where You can measure the physical activity. You can even measure and detect the acute psychological stress, infections. And there again, you are integrating the devices for adjusting the dose of insulin. And this is probably going to be the immediate future. The fully automated, multi-variable automated insulin delivery device. And almost all of them are already there. You know that there is an open source algorithm. There is a DIY automated insulin delivery. And some of these aspects are already there existing, where you discuss about 42 variables that can alter the glucose levels. And this is one I was a speaker at the American Diabetes Association. This was an oral presentation on our own telemedicine program, which I won't be discussing in detail because most of you probably could have listened to this earlier. And at the American Diabetes Association, we presented the data of more than 26 years. And this is a paper clipping, which I displayed at the ADA when I was making the presentation. You can see me over there, the Yahoo Messenger. Yahoo Messenger at those times, this was in 2003 when I was in the US, and I'm connecting in my free time with the patient and with my diabetes nurse in India. And this is how there was an uninterrupted use of telemedicine over the last more than 26 years. And this is the workflow of the telemedicine program. We have the multidisciplinary team, and the patients can choose the modality that they are comfortable and convenient with. It can be a social media platform, it can be the web portal, or it can be the email, or it can even be the telephone, and then the team getting back to them for advices. And this is the conventional care where they need to visit the hospital minimum 3 times in a year. And in the telemedicine group, the difference is, in addition to the minimum 3 physical visits per year, they need to have a telemedicine visit at least 2 times every month. And during every telemedicine visit, there is customized diabetes education. And we are also focusing on titrating the dosages of medications, providing them with diet advices, and then focusing on the area where they are usually weak. And this can be injection techniques or rotation of injections, use of a glucometer, and so on. So in summary, this is only a brief of my presentation. Despite a longer duration of diabetes in the treatment arm, despite the subjects being more elderly, they are having a relatively more older population when compared to the conventional group. There was more than 1% reduction in the hemoglobin A1C in the telemedicine group, and also multiple cardiovascular risk parameters also improved. And this is a waterfall plot in red, and this is on the left, clearly demonstrating larger occurrences of complications such as neuropathy, coronary artery disease, cerebrovascular disease, retinopathy, and even chronic liver disease in those who were not on telemedicine protocol. So in my presentation, I made a concluding remark that telemedicine, in addition to the conventional care in diabetes, is definitely found to be far, far superior in reducing the long-term cause and complications in diabetes. So let me, in the next 5 minutes, briefly go through some of the devices that I have seen at the American Diabetes Association on display. This is the Twist AD system. And, what a minute. Is it on? And this is a Twist automated insulin delivery device. And this is not a patch insulin pump. And this is derived of the algorithm is derived from the Tidepool technology, and the bolus using a one device bolus button and retroactive meal adjustments. And this means that once you have eaten again, you can have a carb count, and then you can have a meal bolus. And this keeps on testing. The Twist system can alert you blockage in the pump. Pump blockage is still very common. And this is 9 times faster detection when compared to the other systems. And this is a NIA patch pump. And the NIA patch pump, what is special? It can be a standalone pump, or it can be used along with a continuous glucose sensing device separately, or it can be integrated. But when you are integrating, this is something very unique with Nia insulin patch pump, which is not there with any pump that I am currently aware of. And in this particular device, as you can see over here, there is a single insertion site for both insulin pump and for the continuous glucose sensing. And this is Beta Bionics. And we have been discussing about Damiano for more than 12 years now. Now he has been very successful, and I could witness a relatively large booth at the American Diabetes Association. And this DIY Bionic Pancreas is now commercially available. What is special? This is the only automated insulin delivery device where you need to input only the body weight of the patient, and then the rest is taken care of by the device. It is fully automated. No requirement for carb counting, no insulin carb ratio, no blood glucose corrections required, and fewer manual interventions, and it connects to Dexcom G6 and G7. And it can be used along with a FIASP pump card. So you can see the customized cartridge which comes along with this particular insulin pump. And this is the insulin check. You know, there is a growing space for the connected devices and for the connected pen caps. And this is one example of a cap which can connect to any commercially available reusable or disposable injection pen. It connects to not only the pen, but also wirelessly to the continuous glucose monitoring devices, displaying the CGM data and also the insulin kinetics, and also capable of automating the delivery of device. And this is the Medtronic. Medtronic is also improving, because the sensor technology has been probably stagnant for a long time for Medtronic, and that is why some other devices have come up. And now Medtronic is also geared up for the launch of their small sensor, the thin sensor, and that is a simpler. And on the left, we can see it connecting with the 780G, and on the right-hand side, you can see it along with the connected insulin pen in pen. And these devices are currently not available in India. And this is Sequare. Sequare Simplicity. If you look at me in the camera, you can see that I am displaying this Sequare Simplicity wearable insulin patch over here. So when I am clicking over here, so I am clicking. So this click will deliver 2 units of a rapid acting insulin. So this can be used in patients who are on multiple daily injections, both type 1 and type 2, to deliver only the bolus insulin. And this is a 4-day wear device. And this is a new member from the Tandem family, the Tandem Mobi. So you know the Tandem is having multiple automated insulin delivery devices, and they have the Control IQ technology. It is matching with Omnipod and with the Medtronic automated insulin delivery devices. And this new device is very, very small. As you can see, it is very small, and it is the only automated insulin delivery device which can be fully controlled with your mobile phone, because all the other devices requires a separate monitor or a controlling device, but this requires only the mobile phone for controlling, and it can hold up to 200 units of insulin. And chronic liver disease is also a growing space in the management of diabetology and the metabolic syndrome and the cardiovascular kidney metabolic syndrome. And we are looking for faster and more effective ways of screening chronic liver disease. And this is Liver Fast, and this is soon going to be available in India as Liver Stat. And this is a blood test-based diagnostic test that combines 10 biomarkers along with an algorithm technology for almost precisely predicting the occurrence of fibrosis. And let me touch upon one more area before I conclude, and this is the spot auto antibody testing for type 1 diabetes, because it is worth testing for type 1 diabetes, screening for type 1 diabetes. If you are successful in early detection, you can prevent a decay admission, because in majority of the cases in India and Asia, in more than 99% of diagnosis, the type 1 is diagnosed after the occurrence of a decay. And this can be minimized to maybe 1 or 3% if we can have readily available multiple tests for spot antibody, 2 antibodies, if positive, that usually predicts a high risk of developing. And even now, you have some of these antibodies, that is teplizumab, which can prevent or delay the occurrence of clinical type 1 diabetes if there is an early diagnosis or a early screening modality. So let me take this opportunity to invite all of you to the physical conference. And this is the 12th anniversary edition of our Global Diabetes Convention. And this is going to be 9 days from now. That is 12th, 13th, and 14th of July in 2024 at the beautiful Uday Samudra Resort in Kovalam, in Trivandrum. So I thank Dr. Benshi Sabu and my friends for this opportunity. And thank you, Diabetes India and IDF Southeast Asia. And thank you, dear friends, for your patience here.
Thank you very much, Dr. Jyoti Dev. So that was a very complex area, and it was very nicely simplified and presented. As a lot of sophisticated devices, and I'm sure there may be a lot of questions from the participants. Before going on to the panel discussions, let's take a short break for the message, for the sponsor's message.
How to get started with ICANN CGM. Getting started with ICANN is easy. The ICANN box contains a quick start guide, a transmitter pack, and a sensor pack. All of these are for single use. The first thing you need to do is download the ICANN CGM app from App Store or Google Play. When you download the app for the first time, there will be a guideline to help you learn cautions and important functions of the app. Then, you will need to create an ICANN account with your email address. Once logged in,
Okay, so Dr. Rakesh Sahi and Dr. Jyoti Dev. So we are
Yes, ma'am, can continue.
We'll go ahead with the panel discussion. As organizers, do we have any questions from the participants? Is there anything on the
Hello,
chat
Anmita.
box? Okay, so I would like to ask a question from Dr. Rakesh Sahe. So you mentioned that with regard to LDL lowering, is the lower the better. With regard to cardiovascular risk reduction. Sometimes we see clinicians, they are very much concerned about, having very low LDL levels in patients, as a result of being on a moderate intensity, statins, let's say. So what is your impression, Dr. Sai? What do you have to say? If the LDL levels are, they are very low, if they are very low.
Yeah. So basically, what we are saying is that the LDL levels, the low LDL levels are looked at what the LDL level is at birth. If you look at children at birth, they are in the range of 15 to 30 milligrams in that range at birth. So that is the LDL that we are born with, and so it is said that we acquire throughout our life we acquire these plaques, fatty plaques, and lipid deposition in our arteries, and to prevent that we should have a LDL which is ideally in the lowest range, and that is borne out by several trials which have clearly shown that lower the LDL the better, because when we started off with say 130 maybe 2 decades back, when we had the CARDS trial, which said that when you conventionally bring it down from below 130 in people with diabetes, you see a benefit. And then we had further trials like the Treat to New Target trial and such trials which have progressively brought it down from 130 to 100, and then from 100 to 70, and shown benefits. So each of these trials have shown that each 1 millimole or 30 milligram reduction in LDL is bringing down the events by about 30%. And so that is I think the basis for the understanding that the lower the better, and the longer the duration that you keep it at the lower level, the better is it in terms of reducing cardiovascular events. And I think although there have been some concerns whether low LDL will cause a problem, but none of these have been proven to have any harmful effects. I think Dr. Jyoti Dev or Dr. Amit may also add to give their views on this.
I completely agree with the statements made by Dr. Rakesh. And I think most of the patients are tolerating very well. But I always used to have a question, what do you mean by saying tolerance? Because in the statements made by all these organizations, we used to make a statement that we can give up to a dose where they are tolerating. So I don't know the meaning of tolerating, because some
Yeah,
patients.
I think when you're looking at tolerating, we are looking at the dose of the statin that we're tolerating.
Yeah, what side effects they are going to develop? Because majority of the side effects, such as muscle aches and the pains, in some of the studies, they have seen that it's same as placebo. So, and some patients in high doses, they may complain to you that since LDL is very low, I am having memory loss. So nowhere it is written that you need to stop or reduce if there is a memory loss. So how do you define the tolerability? That's a big question.
And I would just like to add, it is also true, sir, that a large number of patients, they are labeled falsely intolerant to statins. And this is something, there is a clear-cut definition that when do you label somebody as intolerant to statin. So I think we should follow that. And because of that, even sometimes, and there is always a, this is also very true that sometimes initially a patient may not be may develop some kind of symptoms, most likely the leg cramps and something like that. But you can always reintroduce the statin after some time and gradually increase the doses of the statin. So there are some strategies where you can, which you can utilize to minimize the symptoms if somebody is developing. Otherwise, I don't think there is any contraindication to statin.
Yeah, I also agree. There is no contraindication.
Yes.
All these symptoms are actually not attributable to statin.
Yes. So first of all, before Dr. Dimuthu asks you another question, I would like to congratulate both of you because both the presentations, they were excellent. And those, because I was personally in person attended the ADA and saw the exhibition also. So it was things coming alive again. So the presentations you have made, it's so beautifully that it summarizes almost each and every in very detail what has actually been discussed at the ADA. So many congratulations to both of you. We have Dr. Bansi sir is also there. Probably he would also like to contribute to the discussion. So if Bansi sir, if you are there, then please you can switch on your mic and you can be a part of discussion. Dr. Dimuthu, please carry on with your.
Okay, so do we have time for another? Do we have time for another couple of questions?
Yes, we can take a couple of
Okay,
questions.
so one more is with regard to this LDL, the topic done by Dr. Rakesh. So I found that the India specific, the Lipid Association of India's, that the guidelines which are shown, it's quite interesting. So I was just wondering, I mean, what the characteristic areas are compared to the international guideline. So I was just thinking about, you know, the adoptability, you know, by the regional countries.
Yeah, so I think I just brought in this because it is interesting to know what our local guideline is speaking of and how it is different from the international guidelines. And so basically, if you look at the LAI guideline, it is basically looking at stratifying people based on the risk, based on the presence of these. They've categorized the major cardiovascular risk factors, the risk modifiers, the risk enhancers. They have tried to integrate all these factors in so as to get a comprehensive risk assessment. And based on that, they have highlighted the targets to be different in different subsets of our based on the risk. I mean, those with a low risk, the target would be, say, LDL target would be 100. But when you look at people with higher risk, then you're going down to, and those with very high risk are those with previous cardiovascular events and who have got, who have probably target organ damage further in addition to that. Then they become very high risk category, which requires a very stringent LDL target. So I think that it's very good that you are integrating all these risk modifiers, risk multipliers, and the risk factors, and getting this stratification of the risk. So that is an interesting sort of stratification that they've done.
Okay, thank you, Dr. Rakesh. So Dr. Jyoti Dev, with regard to your topic, diabetes technology, you showed the latest device, the smallest device, the sensors. We've got up to now. So that is Freestyle Libre 3 Plus you mentioned. So cost-wise, I mean, how would you compare it with the previous version?
Yeah, that is an excellent question. Libre 3 Plus is approved for 15 days, whereas Libre is approved for 14 days. And Descom is also there 7, which is almost the similar size of Libre 3. And these are 70%, approximately 70% less when compared to the currently available devices. And I will say that in the countries that this has been launched, the price is always matching. When it comes to countries such as Sri Lanka or India, where it is not covered by the insurance, in India, I suppose it is going to be approximately 1,000 rupees more than Libre. But since these devices are not available in our country, we don't know the exact price. But unfortunately, with all these newer devices, instead of they reducing the price is actually higher. With every innovation, it is actually higher. So that is why I was discussing about the artificial intelligence and the machine algorithms and the DIY getting approved. So when the do-it-yourself created by the patient community themselves are getting approved, and when they are themselves organizing and not associating with any other pharma, and when they are directly doing it for the patients, it might come down in future. The cost might come down, and you know that multiple players are now there for continuous glucose monitoring. And obviously, in the near future, the cost will be less.
Okay.
Yeah.
So I mean, are you able to get real-time data from the latest version of this Freestyle Libre device compared to the previous one?
Yeah,
Is
yeah.
it real-time data capturing?
Yeah. That is a good question, Dimuthu. The Freestyle Libre and Freestyle Libre 2, you require the flashing. They are flash glucose monitoring devices. Freestyle Libre 3 and Libre 3 Plus are real-time devices, and the device doesn't require a near-field communication. You require only a mobile phone with the basic Bluetooth connectivity. Similar to the Guardian Connect, it is real-time and with alarms for hypo, hyper, and so on. So it is real-time and also integrated. It is iCGM, it is not ISCGM, it is integrated CGM, and it is also RT-CGM.
Okay. And so one more question, Dr. Jyoti Dev, as you mentioned about this autoantibody testing, the test kit, which could be used as a screening test for type 1 diabetes. Am I correct?
Absolutely.
Yes, what is the screening populations? What are the recommendations?
I think the recommendations are only emerging with a very strong family history of diabetes, number one, because you will see that the siblings for them to develop type 1 diabetes is relatively high. And I am actually showing here the blood spot collection kit. I have the kit with me, and this is one which was displayed at the ADA. And these are the kits which are available for, and it is soon going to be available in India as well. And this will test the autoantibodies, and I believe that this is important since more than 90 to 95% of type 1 diabetes subjects are being diagnosed at the emergency department with the diagnosis of diabetic ketoacidosis, and then the trajectory changes. So if they are diagnosed without a decay early enough, then there is an option for better treatment. And for a longer time, you may probably normalize their C-peptide levels. And the guideline for screening, I think Dr. Benshi may be able to enlighten more on this, because he's in the he's in the forum for that particular one, ISPAD, and the international organizations such as ATTD, they are working on having a protocol on whom to be screened for type 1 diabetes. You know that type 1 diabetes is no longer a disease of younger age group alone. Many adults and even elderly are also developing, and probably we are not making a precise diagnosis where the antibodies will have a role. But once it is well established, you know, the antibodies might disappear also.
Yeah. Whom to be screened? Yeah, thank you. Whom to be screened? I think we need, we need to establish, the criteria. So I was just wondering, out of type 1 people, the majority of them would not have a family history. I mean, unless we check genetics, I mean, do genetics, it's quite unpredictable. I mean, who's going to develop type 1? So that's why I thought, what are the basics, like the basis of, developing criteria as for the, the screening population?
In general, probably the thinking is closely aligning with immunization. Maybe most of the children need to be screened, since the occurrence is also, the prevalence is also increasing nowadays. Maybe in the developed countries, they might start screening every child. But I understood.
So, for example, I would just like to add, Italy is the first country where they have made it mandatory screening for type 1 diabetes in all the children. And they will start screening at a very early age and will continue to screen at multiple times till they attain the adulthood. So Italy is the one, and closely the many other countries who have resources, they are adopting type 1 screening for type 1 diabetes as a part of their program. But right now, what people are saying that if we are able to identify the population at risk, at least what we can do is the screening of the siblings, and so that prevention of type 1 diabetes, we know that now we have a tool, such things can be offered. And community screening is something which is not right now indicated anywhere. So, but it is for Italy, I think they are the first one in the world to adopt it, and they have recommended a community screening for each and every child.
Which country? Italy.
Italy, sir. Italy. Yeah.
Italy. Oh, fantastic. Thank you for that information. Yeah.
And another point which you mentioned is, Dr. Jyoti Dev, I found very interesting. You said that out of the chronic diseases, diabetes is probably the best example for being a quantifiable disease. So I found it very interesting, that comment. Out of the NCDs,
After the NCDs, because here the whole treatment program is based on lab results and multiple anthropometric measurements. So it is in the it is numbers, and these numbers can be fed into the computer, and the data can be fed for learning purposes, for machine learning purposes, for creating the algorithms. And a similar learning process which can last for 10 years or 20 years, because you can have the same patient followed for multiple years, for more than 2 or 3 decades, for the algorithms to be created. And in diabetes, when you are creating an algorithm, the hypertension is there, LDL is there, HbA1c is there, multiple glucose levels are there, the continuous glucose monitoring data will be there, liver stiffness measurements will be there. So all these parameters, so it is not just diabetes, it is a cardiovascular kidney metabolic syndrome where the multiple parameters can be, the data can be used for training and learning purposes, not for the, but for the machine. So that is why it is said that when compared to cancer, for example, or when compared to some other chronic illnesses, this is probably the easiest, because it is a syndrome where multiple other illnesses are also there along with the syndrome. It is a conglomeration of multiple other disorders where it is easy for the machine to simulate and learn. And people have already done it. People have already done it. It is already there for personalized prediction and treatment suggestions. So we have to ensure that the role of the doctors will be still existent after 10 years.
Do you have any questions, Dr. Gupta?
I don't think we have any more questions, but I'm sure that today's discussion has generated a lot of interest among the listeners and all the colleagues here, because Dr. Jyoti Dev has shown a lot of new tech, which is already there and may come very soon in India as well. And Dr. Rakesh Sahay has shown that what can we expect in future in the management of lipids. So I think with this we can conclude. I would like to thank Dr. Dimuthu for the wonderful moderation and for joining from Sri Lanka and doing a wonderful moderation for this program. Dr. Rakesh Sahay, the president of RSSDI, Dr. Jyoti Dev, the president of DTech, Diabetes Technology Trust of India for wonderful presentations. I'm sure all the colleagues, they have found it useful. And we have Dr. Bansi Sahu sir here. And so I can request him to finally say a few words and propose vote of thanks.
First of all, thanks, Amit, for
Sir, I think joined from couple of devices, you need to.
Yeah, he's on multiple devices, I think.
okay. So you conclude, Amit, then.
2 devices are on Benchy Bhai.
So, I think there is some problem with the devices, so the voice was echoing. So,
One is human and the other is AI.
yes. Yes. So, many thanks to each one of you. And just a reminder to all of you that please join us for the prayer meeting tomorrow at 8:30 a.m., which we are holding in the fond remembrance of our late president of IDF, Dr. Shaukat Sadiqur. But sir, now you are on one device. I
8:30
think you can
a.m.
say yes.
IST. 8:30 a.m. IST. We just highlight that.
Yes, it is
Yeah.
8:30 a.m. IST.
Expect
Yeah,
people
it is in the
from
morning.
all across the
It's
world.
a Indian time, which is very important, everyone should remember.
Yes. So with this, we would like to take your leave for now, and let us reconnect tomorrow at 8:30 a.m.
Rakesh,
for the
please
prayer
join
meeting.
from RSSD.
Sure.
Please join. Rakesh. Okay, boss. Bye.
Yes.
Good night.
Thank you everyone for
Thank
your
you.
patience listening. We reconnect tomorrow. Thank you once again, and thank you for
Thank you. Bye.
responses.
Good night.
Thank you.